Well, welcome back. For those of you who haven't been to a session before, my name is Lindsay McMillan. I'm a family doc in town, and this is Angie Hollinshead. She's an amazing RN who is passionate about menopause education and care. This is all her brainchild. We give her full props. So thank you for coming back over and over again every month for those of you who are back. This evening our talk is about navigating health systems, navigating healthcare and advocacy for family members and loved ones. Take it away, Angie.
So for the majority of us who are here, I think we don't have as many family members as we thought, but we are going to, this is recorded, so please share it. I do have a lovely attendee whose husband I know as well and says, "Oh, we watched you in bed last night." And I'm like, I'm not sure how I feel about that. She will probably laugh when she sees this week as well. So for a lot of us, it's going to be a review because you guys have already been to most of these sessions, but this is going to be very geared towards our family members who are in attendance tonight or any other night in bed or elsewhere. So menopause, for those, especially our family members, why is it important to talk about it? Most women will spend a third to half of our lives postmenopausal. So it's kind of a big deal. It impacts the whole person, our minds, our moods, our body, and our relationships. I did a talk for Enliven last night on menopause and cancer, and one of the young gals who was put into surgical menopause had said, "Will the brain fog ever go away?" It's been a couple years since she's had been put into menopause early, and I said, I actually don't know. Like, I know the natural phase of menopause, they say usually after a couple years post-menopause, things start to level out. People show up early.
Oh yeah. not to point you out again.
Only because you said it was okay. Well, my ADHD got the better of me last time when I completely pointed her out because I couldn't stop it. Anyway, so so there's things that we don't know, and lots of research needs to be done. So that's one of those things. So it impacts that's ADHD, right? I don't have a script. So our mind is a big one, and our moods especially. So for our family members who are here, this is going to be a big topic, lots of patience, lots of understanding. And why else talk about it? Because there's a ton of misinformation out there. Every expert has a very specific, or so-called expert, self-proclaimed sometimes, has an opinion about it. I actually heard a really good analogy about this. It's like, people don't talk about building a bridge if you're not an engineer, because you don't build bridges every day because you don't know what it's like to build a bridge. So we don't talk about being an expert on building bridges. But all of us eat food, and some of us move our bodies a little bit more than others. And so we feel like we have an opinion or a valid expertise on it because we eat the food. Or because we've learned a little bit about food, but we don't talk about building bridges. So I thought that was a great analogy to kind of be like, who am I listening to when I'm looking for information? Is this person an expert by every right? Just because they have letters behind their name doesn't make them an expert, but so just being super cautious about who we're listening to. And then why talk about menopause? Because you can make a big difference. Oh, this is for the family who's out there listening. You can make a big difference in how,
honey, are you listening?
How we experience this transition. We literally made this for Pat and Jer. No, I'm just kidding. Just kidding. That's a joke.
Oh, this is
okay.
Good.
So how do we do this?
I think you just
press the play.
And
listen, I was in an aeroplane the other day, and I realised, I've been longing to say this out loud. So, women are born with pain built in. It's our physical destiny. Period pains, sore boobs, childbirth, We carry it within ourselves throughout our lives. Men don't. They have to seek it out. They invent all these gods and demons and things so they can feel guilty about things, which is something we do very well on our own. And then they create wars so they can feel things and touch each other. And when there aren't any wars, they can play rugby. And we have it all going on in here, inside. We have pain on a cycle for years and years and years, and then, just when you feel you are making peace with it all, what happens? The menopause comes, the fucking menopause comes, and it is the most wonderful fucking thing in the world. And yes, your entire pelvic floor crumbles and you get fucking hot and no one cares, but then you're free. No longer a slave, no longer a machine with parts. You're just a person in business.
So that's one opinion. It's from a show called Fleabag. I don't know if anyone's seen it. I just, the more I watch it, the more I get out of that monologue. I think it's great. Before we move on, I have to give a special thanks to the Good Food Co-op for donating their time, energy. Thank you so much. Where are you? There you are. Thank you. Thank you so much for coming and supporting us. I don't know if it's going to play or not. Let's see.
So again, just to review for many of us, what is menopause other than horrendous by some accounts? That's perimenopause, actually. Menopause itself is liberating. No, it's defined by 12 months after the last period. It's literally one day, as we all know. And perimenopause is the horrendous part often for many of us. 70% of us approximately, actually. And it's the years before menopause, and it can last anywhere from months to like 10, 15 years. So yay. And then post-menopause is everything after you are menopausal. And then there's natural menopause, which is just the natural progression of menopause as we go through life. And then induced menopause as well, which I was talking about a little bit before. So surgical or chemical from chemotherapy or other drugs and radiation. And then, of course, menopause is not a disease. It's not something to be cured or fixed. It is something to understand, but it's inherently not a disease. And it doesn't, but it does deserve support. That's why we're all here.
So another quick review, the menstrual cycle. So as you can see, early in the follicular phase, we have LH and FSH. These are two hormones rising, as well as the estrogen. This is the first part of the cycle after we finish our periods. High energy, higher libido, want to take on the world, and then we ovulate, and then it's downhill. So the estrogen drops off, we start feeling bloated, sore boobs, and then the body is basically creating an environment to grow a human if the conditions are right. And that's why our bodies, we kind of involute. So it's more introspective, typically. The layer of the endometrium, the inner lining of the uterus, is building, and then we have our period, and then the cycle starts again. So this is pre-menopause. This is from when we have our first period to when the change begins. Then, the hormonal chaos of perimenopause. So I'm under no obligation to make any sense to you. This is what happens. This is the difference. So in the 5 years before menopause, menopause being 1 year after your last menstrual period, total chaos. Estrogen and progesterone, up and down, up and down, up and down, until they eventually settle in to the postmenopausal period. And how that looks, we're going to talk about some of the symptoms of perimenopause. Lots of fluctuations in mood, fluctuations in body temperature, fluctuations on attitudes towards our family members, spouses, and the like. But as you can see, it's a very chaotic time in our internal bodies and hormones. So never pick a fight with a woman older than 40. They are full of rage and sick of everyone's shit. So some of the common symptoms that go along with this hormonal chaos of perimenopause and menopause most commonly are what we call vasomotor symptoms. So those are hot flashes and night sweats.
How hot do I get at night, Pat?
Yeah. Super hot. You got that one right, Pat. Good work, buddy. There's more coming your way. Brain fog, memory issues.
How often do I forget things, Pat? He's like, you've been trying to clean, haven't you? Because nothing's done, but everything started.
Mood swings, low energy, sleep disturbances are very common in the menopause transition. Pain with sex and vaginal dryness. Estrogen feeds the lubrication and the laxity of our tissues of the vagina, and when we don't have estrogen, there can be changes which can cause uncomfortable sex and dryness, and then joint pain, weight changes, redistribution of weight into kind of the central area, all can be very common in this transition.
I must talk a little bit about sex.
Good, yes.
Because it's important for some of us. Because we'll talk about this on a different session where it is just the gals, but for the partners in the room, I think sometimes we are conditioned by society to feel like need to be like Michelinas, like hot and ready in 5 minutes, or what do they call that? Little Caesar's pizza,
hot and ready
in 5 minutes, right? And that's not always the case, because now we have this list and that list, and this is going on and that's going on, and so that's a complete myth. A lot of women just need a little bit of cranking of the engine, so to speak. It's, what's the term that is that?
Foreplay.
Oh, I know all about that. Right, Pat?
Wink, wink.
No. Oh, no, it'll come to me later. But there is a term, responsive desire is the term for that. So instead of being, and the same goes for men. I think men are expected to be standing at attention when, like, on a dime's notice. So, but that's not the way it is. So we have more responsive desire. We need a little bit more, maybe some flirting during the day. It's going to take longer than 5 minutes. So, plan it out. Anyways, have some patience. And no, she's not Little Caesar's Pizza.
And like female, like there's lots of different combinations of partnership, but the same philosophies.
I'm just, sorry, Pat, I'm looking at you. Not on purpose, though.
Not on the spot.
Everything's fine.
He's like, I'm never coming to another one of these sessions again.
I said, are you sure you don't want to go to the gym?
He came in tonight and I'm like, oh, it's so great that you're here. He's like, I just wanted to make sure you weren't drinking beer once a month. I needed to check in.
Trust but verify. So, supporting our partners, our family members, what can we do to help her feel supported? Listen with curiosity and not correction. This is a big one. I know lots of people, and I'm a fixer too. I do it with my kids. Jump in as soon as they have a problem, I want to fix it. And so take a step back and just listen and try to understand. And Pat's gotten really good to say, what do you need from me right now? And I could see him, he's like sitting on his hands like a kid in class. I really want to fix this. I know that I can fix this. But he's like, what do you need from me right now? Validating the experience, that goes with anybody in our lives. Offering practical help, so helping with pets, helping to drive to appointments. I think we still take on everything a lot as women, intentionally or unintentionally. Sometimes that's the dynamic of a relationship. Sometimes it's wanted, sometimes it's not. Encourage her to ask questions and get a second opinion if needed. So especially when it comes to going to the doctor, and we'll talk about that in a bit in terms of advocating for yourself. And things not to say. Geez, someone's in a bad mood. Or have you tried yoga? Why don't you just calm down? Relax, it's not that bad. Well, my mom never talked about this.
I hear that all the time.
Yeah, I know, right? I'm like, don't bring your mother into this.
Yeah.
It's probably just stress. It's maybe just anxiety, or, just try to be a little bit more supportive than maybe we are. And sensitive and understanding and patient and maybe a bit of space. One of my friends for Mother's Day received the gift of being alone. And I was like, oh, that is nice. I like that gift. Yeah. Is that me as well? Oh, it is me. Okay. The emotional side of advocacy. So I think we kind of I think these slides are a little bit out of order, but that's okay. You guys will get the point. Navigating healthcare can be exhausting for women especially. We are gaslit all the time, often. I shouldn't say all the time, but often dismissed. There's been a ton of studies out there that have shown, like women's, I think we've talked about this before, but women who come in with chest pain or have heart attacks have a higher morbidity and mortality rate because they're not taken seriously. So women are gaslit all the time, and navigating healthcare can be an exhausting experience for a woman especially. Many of us are or feel dismissed by our providers, and like I said, medical gaslighting for sure. And as a partner, a family member, our support can help buffer against that. Just really be in their corner, like, you know what, honey, something's off. You need to keep pushing for this. I don't know what's going on, but let's go. If you want me to go in with you, sometimes just having that presence of somebody else can make a difference. And for the partners out there as well, you don't have to understand menopause to show up. Just be a bit patient. And we do have a daughter in here, which is great. But I have teenage boys. I'm thinking, who invented going through menopause and having teenagers?
At the same time.
I'm like, this is not okay. Because menopause is basically puberty in reverse. But we've got mortgages, and we've got kids, and we've got a shit ton of responsibilities. So we were going through puberty, we could have our ups and downs and moods and stuff. We didn't have the responsibilities, but now we've got the weight of the world on our shoulders, and that doesn't change through the hormonal chaos.
Okay. And our original talk was on navigating the health system. We kind of got carried away with the supportive partner piece, but I think it is important, and I think both navigating the system with a supportive partner is very important. My advice as a physician, if you have a primary care provider and you're having symptoms that are concerning that you might think are related to menopause or the menopause transition or perimenopause or something more concerning about irregular cycles or that sort of thing, I would encourage you to book an appointment with your primary care provider, whether it's a nurse practitioner or a family doctor. We have in town in Huntsville the annex. Unfortunately, it's getting busier and busier, but it's a clinic that's attached to the library that actually serves all the unattached patients in town. If you don't have a primary care provider, that is a way to access the system. Go and talk to your primary care provider if you have any concerning symptoms. Tell them about your symptoms. Be prepared. Have a support person, like Angie was saying, if you think it would be helpful. I am a big fan of the menopause rating scale, so I think we might have sent it in an email earlier in the year, but we'll send it again with the follow-up email, and I'm going to show you an example shortly. It's basically tracking your symptoms, severe, mild, vasomotor symptoms, and it goes through. I think that's an important way to prepare for a visit if you feel like your symptoms are related to menopause or the menopause transition. Advocate for yourself. Talk about your symptoms. A really important piece is how those symptoms are impacting your life. Are they impacting your sleep? Are they impacting your ability to function at work or have meaningful, loving relationships without too much conflict? It's really important for us as providers to know how much these symptoms are actually impacting your life, because it will help us with investigations and treatment options to offer. So discussing your options. Do I need investigations because of these treatments? Do I need an ultrasound to check the lining of my uterus? Do I need blood work? Again, I'll talk a bit about treatment. I do not advocate, nor does our current Canadian guidelines, against checking hormone levels to see if you're in menopause. There's many other ways, most importantly the symptom tracker, but talking about options, whether investigations are needed, and treatment options. If you are blocked, Angie's like, what do you mean by blocked? It's like being dismissed or not heard, feeling unheard by your primary care provider. There are other options. You could advocate for yourself by saying, I'd like to have a referral. When we refer to gynecology, our 2 referral centers, if you're north of Huntsville, you would go to North Bay Gynecology, and Huntsville and south to the Aurelia Soldiers Memorial Hospital, which have an incredible group of gynecologists. Unfortunately, like with many specialists in the healthcare system, there is a very long wait list, but there's certain investigations that can be done right here in town. So if it's found, for example, that you get an ultrasound and the lining of your uterus is thicker than it should be, and there's a recommendation for an endometrial biopsy, you actually do not need to wait for 12 months to see a gynecologist in Aurelia. The group of women's health doctors that also do obstetrics, me included, have a clinic as a part of our OB clinic to do endometrial biopsies, to do IUD insertions and other certain procedures that other family doctors in town don't have, and we have a special designate for that. So you can always advocate to get a referral if you need any of those investigations while waiting for a referral. And the other thing is the Women's Health Hub. So this is evolving next year. We had a meeting last week on Friday about what it's going to look like. Very exciting. It is going to be in the annex, so attached to the library in that clinic. They've provided space to us one Friday a month. We're going to give you lots of information in the coming months about it, but in general, if you are not attached and you don't have a family doctor, we will still take the referral, and you'll meet with Angie and have intake, discussion, options, and then decide whether you need to see one of the physicians. Or you can get a referral from your primary care provider. Because the group of us have a special designate in women's health, there's this thing in our medical system right now. If one doctor sees you, but you're rostered to another, they'll get dinged, and it's a big political thing. That won't happen. It's not a thing, because we have this women's health subspecialty. So advocate for yourself. These are kind of the local lines of how to get the help you need if you can't with your primary care provider. And then other things. There are so many disciplines of healthcare providers in our community. Mental health providers, osteopathy, naturopathy. There's lots of different modalities that you can also explore to see if you can get the help you need with various symptoms. The biggest thing, and the reason why we're doing what we're doing, is build your tribe. So more community, more people talking about this, advocating for yourselves creates strength and empowerment within our group. So build your tribe, and that's what we're hoping to do through this.
Another option to there's a gynecologist, I believe, from Peterborough that is going to the Minden Hospital for anybody who kind of lives closer to that area. And
brand new.
Yeah, she's running a gynecological clinic out of the Minden Hospital.
She literally just arrived to town, so that's great.
Yeah, and I think she takes unattached. Like, I don't think they're just doing a Papapalooza.
Oh, I'm doing one of those in June, too.
But I don't, and I think you can just go. Like, I think you can just make an appointment, from what I understand. So there are some options, and I've heard some really great things about a few gynecologists in Peterborough who work out of the Peterborough Hospital. But again, how far are you willing to travel? But if it's less than a year and they're really good, there's some options kind of in the area within an hour and a half drive. So. So how to navigate the healthcare system in menopause, like Lindsay said, knowing your symptoms, that's the biggest thing. So I always like to create some sort of scripts as well, a little bit of script tips to help people through it. So say something like, over the last 2 weeks, I've had hot flashes every night. They've disrupted my sleep. They wake me up 3 to 4 times each night. I'm soaking the bed. I, just really be descriptive. Try not to minimize. I know every time I go in to see my doctor or something, I'm like, okay, this time I'm going to go in and I'm going to be firm about what I'm going through. And I'm like, my knee hurts. Oh, what's going on? Oh, I don't know. It's okay. It's okay. Don't worry. Don't fuss over me. I'm like, good Lord. Like I prepped myself for this. I even gave myself a pep talk. Because I think I don't want to bother anybody, and minimize the symptoms, right? So anyways, try to stay strong. Research. We talk about this a lot. I'm not an expert in everything. I'm a strong and passionate and advocate for women's health, but I don't read all of the studies. Half of them make my eyes go cross because it's just too much. And so you've got societies like the American ACOG is the gynecology one, right?
The American Gynecology Obstetricians.
American College, that's what the C was, of Obstetricians and Gynecologists. That's a great website. SOGC
That's
is
our
the Canadian version. I can't remember what the Canadian Society of Menopause, I think. I don't remember what all those are actually. I had them written down in a different presentation that I did
They're
last
all
year.
reputable sites,
Yeah.
though.
The North American Menopause Society, which is now called the Menopause Society. Those are all excellent websites as well to get some good information from and debunking myths and things like that. It's okay, and I think it's okay to research things and go into your family doctor or your primary care provider, but just be like, hey, I was kind of looking at this. Like, what do you think? I don't know what gets doctors' backs up. Some of us, other than a few in the community who, anyway, I won't say anything. Okay. I think we're tired. That's okay. So, so things like I've been struggling with hot flashes and sleep disturbances. My goal is to manage these symptoms without significantly impacting my day-to-day life. And I'm open to discussing both hormonal and non-hormonal treatment options. So just be like, hey, I've done a bit of research. These are the things I'm interested in. What do you think? What are my risks? Shared decision making is a big term, I guess, or phrase these days. So, ideally you're going in talking to your primary care provider about what's going on and being able to say, yeah, I really do. Like, you've explained the risks really well, but I'm still willing to try it. I'm suffering so much that I know that I have an increased risk of, let's say, breast cancer, because that's a common one that people worry about. But I am just like, I'm dying here. Like, give me something, at least for 3 months. Is 3 months going to make a big difference? Probably not. So advocating and just really being descriptive.
Oh yeah, this is just a copy of the menopause rating scale that we will send around. Yes, being a woman is fun because no matter what symptom you search, you are either dying or in perimenopause. So this is just the example. I'll send it around, the menopause rating scale, which can really help you on your journey as to where you are and how much it's affecting your life, and also helping advocate with the healthcare system and your primary care provider. The other thing is we all in town in Huntsville always have learners. And what I've been finding with the medical students and the residents that are coming through and working in our office, they're more educated about menopause. So that really excites me. So if you happen to have a primary care provider, it might be an advantage that someday they ask, oh, do you mind seeing the resident first? Because I find that they're more knowledgeable than some of the older docs, sorry to generalize, and they can help you advocate for the care that you need. Working with healthcare providers. Do you want to talk more about this? It's a teeny tiny.
It is a teeny tiny because I copied it off that other one because I removed all these slides initially. I'm like, wait a second, I took out all the slides of the topic we're talking about.
She showed up tonight. She's like, I think I removed all the slides about navigating the healthcare system. I'm like, yes, you did.
Whoops.
So we stuck them back in there. Yeah.
Can you go back to the last slide?
Yes.
How do you decide mild, moderate, severe, very severe, given the fact that we tend to minimize?
That's a really good question.
Is there like this happens 5 days out of 7, this happens
Yeah,
3 times a week?
it's not specific, and I think that's part of the point. It's your own perception of how much it's affecting you, but that's a really good point. We're really good at minimizing things as women. The thing is, you do this and then you do it a month later, like you keep checking in with yourself so you can compare your own numbers, right? You're not comparing to a gold standard that we have behind our desk when you come to see us, right? It's just your experience and then how that experience compares from month to month. So this would be something you'd be doing.
Maybe notes for your own self-reference. if you're
Exactly.
comparing it from-
Self-reference, exactly.
Yeah, especially if you start any sort of a treatment. You want to see if it works or not. So you can subjectively, or even different times of the month, like depending, right? You can do it as often as you want or as little as you want. But yeah, it's completely subjective, but Yeah, that, like you said, that's a good point. There's no gold standard for it, because
Yeah.
it's all
If-
your
if- yeah.
lived
Yeah.
experience.
If you're a 4, then you get hormones. If you're a 1, you don't. It's not like
No.
that. It's just more subjective and based on your own experience.
Yeah, or if you've changed
yeah.
something, like if you've changed something in your diet, let's say, if somebody said, I stopped drinking alcohol, I want to see how this impacts my symptoms, keep track of it. Or coffee, or whatever it is. If you've changed something, you want to see if it impacts it. It's just a good way to kind of keep track of it, because we kind of forget over time as well.
Any other questions at this juncture? Andrea?
So my question is probably for you, Lindsay. When you call to speak to make an appointment with your doctor, like this isn't like I find sometimes the doctors it's just rushed, right? Like the appointments are shorter than when you go to your naturopath. And sometimes I wonder, like, so if you have your yearly physical though, it feels like a longer appointment. I'm not wrong, right?
It's 30 minutes, not
Yeah,
15.
So if people are making an appointment to discuss all these things, do you recommend just like requesting a certain time for an appointment? Because it seems like
I think that's a great question. So should we be requesting more time for the appointment? 15 minutes is not very long to kind of do a thorough history and physical exam related to menopause, but nor is many things, and we just have to, get through as much as we can. I would, if your doctor has, or primary care provider has an option, I would really like some counseling around menopause. Could I have 30 minutes instead of 15? I think that's very reasonable. I don't think it could be fit into that 30-minute physical, because there's so many other things that we have to.
I was like wondering if you were
Yeah.
allowed to have longer appointments.
It depends on the provider. In my office, all of the providers in my office would give 30-minute appointments for certain counseling. And menopause, I think it deserves that time.
So you just request that when you make your appointment.
Just ask, yeah. And be specific. So when I go in for my day, I see who's coming in and what they're coming in for. When you call and you say, oh, it's about this, I would say menopause. I had one of the locum doctors come up to me this morning and say, Lindsay, my first patient, she's here for menopause. Can we do a quick debrief she just asked some specific questions. So it's good for them to know what you're coming in and not to just, because then the provider kind of wraps their head around what the discussion is going to be like and what you're going to be talking about. Yeah, but I think 30 minutes is a great idea if you can do that with your provider.
If they offer it.
If they offer it, yes.
Yeah. Unfortunately, I think the system isn't set up appropriately with, just the way the whole system, it needs an overhaul, as we know.
That's for sure.
Yes, when you do get there for your 30-minute visit, because we're going to encourage our care providers to give it. Do they get paid appropriately for that?
If
Like,
it's
is the fee
counseling, we could, bill for the time.
Yeah. I just want to make sure people get billed, or,
Oh, actually, I'm
okay,
sorry to
no,
interrupt.
let's do that.
Speaking of educating our primary care providers in town, part of this whole program, and we talked about this on Friday as well, in September, Angie and I and Maggie and Lisa are going to do a grand rounds with all the family doctors and the specialists and the surgeons. They all attend on a Wednesday morning from 8 till 9. We're going to do a brief review about menopause approaches to treatment as like a refresher for the primary care providers. And then the second half is going to be talking about, and this is our clinic, and this is how to refer, and this is the referral form, and this is what to do, just so you know that we are kind of disseminating that information to the healthcare providers in town, the nurse practitioners, and the physicians.
Yeah.
It's exciting.
Yes, it is very exciting. So when we do get there, we are working with our healthcare providers, effective communication. Like I said, you can never communicate enough. Try to be clear what is exactly going on and how is it impacting your life. Example, I've been experiencing severe hot flashes. They're significantly affecting my sleep and mood. I feel that I need a more comprehensive approach to managing them. Can we discuss options beyond lifestyle changes? Like, I don't know how many times women are told, like, oh, you just need to lose weight. Okay, you need to F off and stop telling me that, okay? Yeah, it's not the cause of everything. So, what's that? Oh, okay. Did you have another word or two that we can use as we go to our doctors? Asking specific questions. What are the potential side effects of the treatment, or how will we monitor my progress? And if they don't seem to know, I think a lot of docs are going to say, I don't really know enough about it. But then you can say, oh, well, there is this clinic. If they're not comfortable. Again, but we're not starting that till October, so I'm sorry if you have to wait till then for people who don't have care providers. Advocating for yourself, again, so if you're getting kind of blocked, dismissed, be like, I understand some of these symptoms are common during menopause. So, people that say it's just menopause, everybody goes through it. Those who've never gonna go through it because they aren't women, but they're seriously impacting my quality of life. Again, giving a detailed description, and can we explore other treatments, or perhaps can I get a second opinion? And then, unfortunately, it's hard to find family doctors, and you end up on big lists. But sometimes we might have to switch providers. So, I really thank you for your time, but I feel that my concerns haven't been fully addressed. And I'd like to ask a second opinion, explore other options, and I'm probably going to try to seek another physician because we're not meshing here. So it's okay to advocate for yourself.
Or to hold on to them and get a referral.
I know.
It's so hard, right?
Yeah, I don't know that process. It's very different. Like in the States, you can just jump family doctors.
There's
it's a fee for service.
6,000 people in
Our
Huntsville that are waiting for a primary care provider right now.
I have a strange off-topic question. How many patients on average does a general practitioner hold?
That's a great question.
Oh.
I know the answer to that.
Depends on how old they are.
Yeah, it's true. Actually, it's quite interesting. So, I sit on the Algonquin Family Health Team board, so we get updates on how many patients every provider has at our monthly meetings. The older doctors have bigger practices.
Massive practices.
I'm talking like 1,500 to 2,000. Yeah. The medium-sized generation of docs, me included, my practice is like 800. And I work part-time and I do obstetrics on the side. So most people who are working part-time, which is really equivalent in my opinion, and Jeremy can attest to this, to a full-time job.
Part-time.
So if a doctor is working like 5 half days a week, they would probably have 900 patients. Yeah. Yeah, and that's like seeing patients, and then we're spending all the other blocks like charting and sending referrals and reviewing results and following up and that sort of thing. So it's the younger folks, I will get to them, the younger folks who are coming in, the younger doctors, and we've had like at least 3 or 4 in the last year, young, either couples or single physicians to come to town, but they all want to practice share, and they want a very small, so they can do other things.
Quality of life.
Because they want balance and quality of life, and I completely respect that, but it's a different culture. So the old guys would see 1,000, 2,000 patients, no big deal. I find it pretty heavy to have 800.
Yeah. 20,000, 22,000?
22,000.
Yeah, and
Yes.
you can see how the older generation, there's then those single doc practices, nobody wants to come into that because they don't have quality of life, and it's spending all their time. It's a passion. Like you got Jerry. There's so many that are going to retire that have these massive practices. So it's tough. We have to get the couples to come. Really.
One of the family doctors in town retired, and then the person who came on said, I can only see half of these patients. So the other half were let go, and it was a random thing. And now that doctor has found another young doctor to split that practice with.
So took a quarter of the patients. Yeah.
So it is an issue in terms of, and our fee structure right now lends itself to, okay, if you have so many patients rostered, like it's not like I need to see this many patients to get paid, and that therefore not as many people are getting seen, unfortunately.
And unfortunately, not everyone understands that. So when you call and you book an appointment and you're like, what, I can't get in for 3 weeks?
Yeah.
Like no one's fully understanding.
Talking.
And they're trying to get more doctors.
Yeah.
Yeah.
The town is trying.
The town has a great incentive right now.
Yes, they have a huge incentive.
Yeah.
They're trying really hard.
there's lots of people in town trying really hard to recruit. People who are nearing the end of their careers are really working hard to recruit. The town is doing a lot to recruit.
It's
more.
Canada-wide, though. I mean,
Yeah.
I think it's worldwide, but they've known this is going to be an issue for a long time and didn't open up as many medical spots as they probably should have in schools and universities. Just poor planning. It was the same with nursing. We all knew this was going to happen, and they didn't open up enough spots in universities and colleges, and now they're scrambling. So it's sad and it's hard, but this is why we're doing these initiatives. I think there could be better utilization of people like registered nurses who get special designations, who can reduce the barriers to access to care. So that was one of the big things, is just like, I don't want somebody to have a referral to come in. I want them just to be able to come in and at least get screened, at least have a chat with a nurse who has a special designation. And then I know that I've got a doctor on these days of the month, and I'm like, yeah, you know what, you've got abnormal bleeding, but it doesn't require an emerge visit. You still need an ultrasound. You'd have to go to emerge to get the referral for that ultrasound. Then who's going to follow up with you? Now I can refer then, or make the appointment right with one of our physicians, and then they get paid properly as well. So so that's why we're doing it. And I'm hoping, we are hoping that this model of care is something that is something that the government or whoever those higher powers that decide the funding can look at and be like, okay, this is a good model. We can start to create these models elsewhere, because everywhere you go, there's a barrier. You have to have a physician's referral, and if you don't have it, there's 6,000 people here who are going to go to the emerge to get a referral to see a gynecologist. Then who follows up with them? It doesn't happen. So,
Yeah.
So on that, and back to our lovely partners and family members, if we are helping our partners and family members navigate healthcare, help her track her symptoms. I know many of us out there, our family members and partners are just like, are you sure it's not coming? No, it's not coming. It's not that time yet. It's like, okay, I'm pretty sure it is. Yep, we're right on time. I don't know why we always feel like we're the last to know. I know I was. I never kept track of anything. Encourage preparation for appointments. Do you have your list? Do you have your symptom tracker with you? Do you want me to come with you? Do you need the moral support and the love? And it's okay to get a second opinion. Don't dismiss her as well, and also gaslight. And offer to review info or research together. See what you can find for yourself as well.
Oh yeah, let's see if this works.
Yes.
Here's a good example. I saw this scrolling this morning before work.
I think she texted me.
Stressed, she's not asking to be managed. She just wants to feel met, not dismissed, not countered, and definitely not fixed. But someone asked me, what does it actually look like when a man does this? It's a great question. Looks like this. He doesn't get flustered. He doesn't roll his eyes. He doesn't leave the room. He doesn't raise his voice or try to overpower her, but he also doesn't shrink. He stays right there, calm, grounded, still. And when she's storming, venting, emotional, when she's in it, he lets it move through her without trying to grab it or stop it. He might say, I'm here, I can take it. He might put his hand on her arm and hold eye contact. He might just stand there and not disappear, which can feel like a freaking miracle to a woman who's never had that before. It's not ignoring, it's holding with his eyes, with his body, with his energy. Because the storm doesn't need to be stopped. It needs to know that it's safe to pass through. When a man can do that, that's when the nervous system finally says, okay,
So
I'm not in this
I'm sure this
alone.
is about another program.
Life is a storm.
here
When she's
we go.
flustered and
Life is
stressed,
a
she's not
storm. Here we go. I liked that. I liked that approach. I liked just holding space, that concept of just holding space. And like Angie was saying earlier, not trying to fix. How can I help? How can I help? Just being there and being there to support your family member going through menopause.
Whether you
through that
understand it or
storm.
not.
Whether you understand it or not, exactly. Now, do we have a slideshow? This has to be the most scattered presentation we've done, Angie. So thank you all for bearing with us. I have no idea how to find it.
I don't know where your little
Oh, maybe it's here?
dewies are.
Yeah. Yeah. Oh yeah.
Look at you
Ooh,
being
so
all
tech, so
techie
tech,
and
so
stuff.
tech.
I'm with you. I love
Yes,
it.
so basically, I'm with you, and I'm standing here with you, being patient. Again, the moods, the memory, the energy shifts, things are real. Check in regularly, learn together, celebrate the wins, and of course, normalize prioritizing health, both of your health. Because if we have partners who are around the same age, our health is going to be along a similar continuum.
Oh yeah. Boop. So this is a quick recap, and I brought some notes just about treatment options. Again, when you're navigating the healthcare system, advocating for your health, and seeing your primary care provider, I just wanted to give you guys a bit of a reminder of some of the options to treat symptoms. So the first thing is hormonal options, non-hormonal options, and then the lifestyle stuff. And I think we've really hit home at each of our talks from different angles the importance of lifestyle, right? I talked to Carolyn Van Dyken, the pelvic floor physio, and she said, I've talked to some women who've been at your sessions and they're getting pretty overwhelmed with the amount of information. And I understand, and that's why we're doing these monthly sessions. There's a lot of info to get through. But if it came down to like the core things, if you could move more, eat more whole foods, get a good night's sleep in whatever way you can, cognitive behavioral therapy is the best, and seek therapy for mental health support, like these are the basics. This is like the foundation of health and well-being throughout your life, but especially during menopause. And then when it comes to actually treatments, there's pelvic floor physiotherapy that Brittany and Carolyn talked about last month, but then the hormone and the non-hormonal options. I'll talk about non-hormonal first. So when we think about treating menopause, it's treating the symptoms of menopause. When I was in my training, I literally was taught if they have a sleep problem, give them a sleeping, not so clearly, but treat their symptoms and not the underlying cause. So these were the early days after the Women's Health Initiative where everybody's like, oh my God, hormones cause breast cancer and heart disease. Everybody off, the pendulum swung from everybody being on hormones to no one being on hormones. So when I came through the ranks of my training, it was if they have a sleep issue, deal with that. If they have anxiety, deal with that. So treating the symptoms and not the underlying cause. Some of the non-hormonal options actually treat the vasomotor symptoms as well as some of the mental health effects and sleep disturbances with menopause. And they include SSRIs, so things like citalopram, Celexa, paroxetine or Paxil, sertraline, Zoloft, all of those via prescription, and I'm happy to talk to anybody about any of those. SNRIs or venlafaxine, Effexor is the other name, can help with vasomotor symptoms and as well as mental health effects of the menopause transition. And also gabapentin can work on the GABA receptors to help with some of those symptoms of vasomotor, hot flashes, night sweats. And then when it comes to the hormone options, I wanted to reiterate, because I had to read it again, what in Canada, the indications for hormone treatment for menopause, bothersome vasomotor symptoms. So that's your hot flashes and your night sweats. I really think most providers in our community, if you're going in with debilitating hot flashes and night sweats, they'll be open to a discussion about hormones. Also the genitourinary symptoms of menopause, which Brittany and Carolyn talked about last month. Lack of estrogen causing changes in the vagina. Our most common prescription is something called Vagifem, which you insert into the vagina twice weekly. It's a local estrogen therapy, which doesn't have a high systemic effect and therefore doesn't have a lot of the side effects and risks. If you're going to be on estrogen, I wanted to say the other indications are prevention of bone loss in postmenopausal women who are at really high risk, so family history or a personal history of a fragility fracture, and then people who've had premature ovarian failure or insufficiency or had to have their ovaries removed for a medical reason. So those are all across Canada, our guidelines about when to treat with hormone therapy. The hormone options are estrogen and progesterone. If you have your uterus, We always recommend you never go on estrogen alone because estrogen without progesterone increases the risk of endometrial or uterine cancer, and the progesterone helps keep the lining of the uterus thin while you're on the estrogen. The contraindications for hormone menopause therapy. So if you are postmenopausal and having vaginal bleeding, that is a contraindication and a reason for further workup and investigations. Pregnancy. We don't want you on menopause hormone therapy. Breast cancer is a discussion that you would likely have to have with your oncologist because there are some newer medications that have less of a hormone effect on women who are susceptible for recurrence of breast cancer or a strong family history. However, having a family history, even with a first-degree relative, is not a complete contraindication to estrogen, but it's worth a discussion with your provider. And then active liver disease, coronary artery disease, history of stroke, all of those things, which can increase your risk of blood clots, which is one of the big things we worry about with estrogen therapy. They are also contraindications, but worth a discussion for some of the other non-hormonal medications if you need or are looking for treatment for symptom management. So that's kind of a general overview. Is there anything you want to add?
I think there's some research that is being done on using ADHD medications to help with the executive dysfunction that a lot of women have during this time. So your memory loss, your scatterbrain, your, the brain fog. So I think there's some newer research coming in on that.
But nobody prescribing hormones for that right now.
No, not hormones,
Yeah.
ADHD meds.
Oh, sorry.
Yeah. But no, they're not, but there's research coming out. But
Yes.
maybe it's worth a discussion. Like I think I mentioned a couple of weeks or last month or whichever that I finally went to my doctor. She's like, yeah, I don't need to send you to a psychiatrist. Your self-screening for ADHD is like off the charts. So started on the low-dose ADHD med, and I will say it has helped a lot with that kind of executive functioning stuff that I was really struggling with. Procrastination, unable to get things done, just spinning my wheels, rumination, like all the things that kind of come along with that executive functioning, because there's a lot. The estrogen impacts that part of our brain a lot. So it's not an indication, but it might be worth a discussion.
I have always women, mostly in this age demographic. It's a real thing, and I believe that there's a lot of ADHD, and I don't think we're overcalling it. I think we've been undercalling it for a really long time. There's lots of providers that are hesitant to prescribe medications because they are, worth money on the street. They're controlled substances. But I definitely think if you're having, it's becoming more, I don't know if it's on TikTok or what, but I am telling you, it is, there are women coming in every week talking about this, and most providers are willing to explore it, refer, or trial medication. I think it's interesting. I've never seen any research with menopause and ADHD personally,
It's
but
coming out.
it's coming. It's coming down the
it's
pipeline.
coming.
Yeah.
Advocate for the sleep study.
Yes, and the sleep studies as well.
Because before going on the ADHD meds, if you can avoid that and treated the actual root cause, potentially, I just want to.
Yeah,
I think that's
absolutely. As like when Catherine mentioned with her awesome presentation before, with sleep, if sleep is the underlying root cause of the problems, then we need to treat that as well. So yeah, great point. Thank you.
So important, and it could save you money and
And side effects of meds. Yeah.
yeah.
Back on that first or second slide, the one that has the menopausal lines and stuff going all over the place.
Yes, way back.
Things that went up when you got.
Oh yeah, your FSH and your LH. So what happens, I love talking about this. So what happens when your ovaries stop functioning and making estrogen, it causes a feedback loop up to the hypothalamus and pituitary gland to say, oh, there's no estrogen. So you upregulate the stimulating hormones, the follicular stimulating hormone and the luteinizing hormone to produce more. It's like, hey, ovaries, come on, you have to start working. So they upregulate to try to get the estrogen and the progesterone to be produced in the ovaries, but it's like too late. So we very rarely check hormones, but if somebody doesn't have a uterus and they're wondering if they are in menopause or not, doing an FSH is a very accurate is this woman in menopause or not, because it's going to be really high. Most of the time, as you saw in the slides, the hormones are fluctuating, so it's really hard to delineate what means what. But with a high FSH, it's the brain saying, what's going on? Why aren't you working anymore, ovaries? That's why it goes
Sending out
higher.
the messengers. I think there was.
Those hormones do.
What is it?
So those, the FLSH,
Yeah.
those letters, if it's going up, what else does those hormones do? Is that their only job?
Yeah, I don't think that's linked to any specific symptoms or signs that I'm aware of.
As far as we know, its
Yeah.
job is it's the chemical messenger that's telling the brain's telling the ovaries to release the follicle stimulating hormone. So it's stimulating the follicles to release the eggs. But now we're like, we don't have any eggs. So the brain's, yeah, like Lindsay said, the brain's
Upregulating.
going, hello, guys, you're not working hard enough down there. Jen.
I have a couple questions about that last slide also. So that time in between at menopause, like that, it's going to start leveling out over time, right? It's not like a moment where it kind of looks like chaotic
No.
and then you hit and then it's like smooth sailing.
It's apparently about 2 years from what I've read and all the research. So when you've got your 12 months, now you've got your 1 day of menopause, because now you've just hit the 12-month anniversary of no menstrual period if you have one, and you know when that day is. And then approximately, from what I understand, approximately about 2 years after that, that's when like, oh, my brain fog's better. Oh, things have normaled out. My body doesn't feel so chaotic. I'm not as moody. My joints don't hurt anymore. The hormones, the estrogens just kind of got to its whatever it's now new, normal, and baseline, and our bodies have adjusted. And this is where this is where we start to catch up to men in terms of heart disease and stuff like that, because now we don't have the protective effects of estrogen. So where men tend to have heart disease and things like that at a younger age than we do because of their testosterone levels, we then start to even out once we get into our 60s, and then we have about the same rates of heart disease after that.
So we always want the lowest effective dose of estrogen, and progesterone is just, I'm sure there's good science, but it's only available in one dose. I know, and if you see the up and down,
I don't want 100 of this if I'm taking 25, like to me that just doesn't.
there are two options for progesterone therapy in menopause hormone therapy. One is a cyclical, so you take it 21 days of the year and then at 200 milligrams, and then not for the last week or 10 days, 21 or 28 days, I can't remember. And the other one is just 100 every day. So this first option mimics the cycle a little bit more, so you get a higher dose earlier in the cycle, and then you have almost like a withdrawal, like your natural hormones. But how I counsel patients is, are you going to remember to take it? Would you rather just take it every day? Because the evidence in terms of efficacy of treatment or how much it helps is pretty even with both options. The estrogen, we always start low, check in with you. How are your symptoms?
3 months or so.
Okay, 3 months. You're still having a lot of hot flashes and night sweats. Let's titrate it up a little bit, because it's so important to have the lowest amount of estrogen in the therapy because of the risks.
More.
Because it works so the question was VagiFem, is there progesterone? When it's local cream therapy that's inserted into the vagina, it stays in the uterus. There's very little amount of medicine that's actually absorbed into the body. So there is no risk of endometrial hyperplasia or uterine cancer with vaginal estrogen. So none of the gynecologists in Aurelia, Toronto, if you're taking vaginal estrogen, you don't need the progesterone. That's a really good question. It's just because there's little systemic absorption, so therefore less risk.
Yeah, I think it's something that's becoming a little more common, that oncologists are actually starting to be more comfortable prescribing for women who have had hormonal or non-hormonal cancers, to be able to prescribe the vaginal estrogen. I think some are getting a little more comfortable, because the risk is so low with especially the VagiFem. But so you don't have to suffer.
That's true.
There are options. Some still may say absolutely not, or may counsel against it. But if you're having significant symptoms, That it's one of those shared decision makings, like just tell me my risks and is that risk acceptable for me? I think that was,
Do you have something?
I have one little slide there.
Any other questions? Yes, Jan?
One about you girls, and I love when you said it's worth a discussion, I love that, but you only have 15 minutes.
Yeah.
So I think, I just wanted to
Yeah.
wrap that in there, but the question is this, when you say you could get a second opinion,
Yeah.
who's that?
Yeah,
You're
so-
doing kind of
Gynecologist.
I'm not talking about myself, I'm talking
Yeah.
about 6,000 Huntsvillians.
Yeah.
This is it. So if you don't have a family doctor, you book an appointment in the annex to talk about your
Correct.
symptoms with a nurse practitioner. I work there. There's lots of doctors in town that spends time working at the annex. Second opinion, in my opinion, is if I can't help you as a family doctor, I'm happy to refer you to gynecology. But again, it's going to be a long wait list. So the second opinion is I'm not getting what I need as a patient from this provider, so I'm going to ask for a referral to someone with a bit more specialty in this area.
It was just the only thing. I pulled up one of my slides. So personalized treatment for menopause
good.
symptoms. So what can influence treatment choices? Treatment decisions depend on several key factors. So your symptom tolerance. Can I tolerate the symptoms that I'm having? Your personal health history, your risk factors, and your personal preferences and risk tolerance. Again, that kind of informed consent. So those are kind of the considerations that when we're talking to our physicians, especially if we're suffering. I think there are women out there who've been, I've had a hormonal responsive breast cancer, but I am dying and it is impacting my life and I cannot go through life without this. I want the hormones. I am willing to take the risk.
We had a woman in our circle earlier on who came up to us, maybe just me, afterwards and said, I have hormone positive cancer, and I chose with a fulsome, informed risk-benefit discussion with my provider and oncologist to go on menopause, exactly, because the symptoms were so debilitating and affecting her life. The benefit outweighed the risk in her mind. So we all have different risk
tolerance,
aversions and tolerance, and it just has to feel right to you. Some people are willing to take more risk for the potential benefits, and others are very risk averse and don't even want to go near hormones if there's any increased risk of breast cancer.
Yeah.
Which is fine. Everyone's different, right? I think that's it.
That's it.
Warning, due to influence of hormones, I could burst into tears or kill you in the next 5 minutes. Honey.
Please be patient with me.